Bismillahirrahmanirrahim. Doctors, let's we start our today's class and today's final class of our 2 week pre-trial classes. So we are talking about the exam pattern of AMC. So in every single topics of AMC, you have to focus on each topic's clinical feature, respected about the investigation, about management, and few topics have surveillance or screening part. You have to go through that. These are a few important things in every topic. Okay, today first question. First question: a man who complains of upper epigastric pain, no presenting with melena and stool. Next appropriate step. Option A, IV pantoprazole. Option B, omeprazole, amoxicillin, clavulanate. Option C, colonoscopy. Option D, sigmoidoscopy. Doctors, everyone to have answer in chat box, please. Later on, we will go with guideline. Please hurry up, doctors. Okay. So few people with option A and few with C, right? And no one with B and D. Okay, let me see with guideline. So answer is IV pantoprazole. Next step is IV pantoprazole. Okay. So doctor, this is the guideline of emergency management of upper GIT bleed. I think this one is not visible, right? So just one. So this one is visible. Okay. So doctor, let's suppose the patient presenting with upper GI bleed and you have to diagnose, and later on if the is minor bleed or major bleed. So minor bleed is not important from exam point of view, but the major one is important. So first of all, you have to manage a patient like vitally stable oxygen. You will pass IV line and resuscitate accordingly 500 equilide of crystalloid solution. Then you have to transfuse if the HB less than 90 in high risk people like coronary artery disease patient and HB less than 90, you have to transfuse. And later on, you have to commence PPI. This one is our answer. Question from this. You have to commence PPI, pantoprazole, 80 mg IV bolus. So dose is not important. So next step is pantoprazole. Next, you have to classify either it is non-varicose or varicose bleed. So this one is important. Question come from these box. So if the patient present with the varicose bleed, what is the mean of varicose bleed? Varicose bleed mean from bleed from the dilate veins like esophagus, stomachs, or maybe the portal hypertension. So this include in varicose bleed. And non-varicose bleed mean bleeding from any like peptic ulcer, from maybe bleeding to the Mallory Weiss tear or malignancy. These in non-varicose. So varicose bleed, for example, you diagnose the source of bleed is varicose. So you will go with octreotide 50 mg IV bolus infusion form. And then second, you will go with antibiotic like ceftriaxone to coverage for infection. And later on, you will go for endoscopy for binding. And so the way you have to manage with varicose bleed. But in case of non-varicose bleed, what are the next step? The next step is early endoscopy. Next best step, early endoscopy. And if endoscopy is unavailable or contraindicated, you have to consider interventional angiography, or you can go with octreotide 50 mg IV. So in variceal bleed, the first next step is octreotide, and later on you will go with endoscopy. But in non-variceal bleed, the early step is endoscopy. So you must know how to differentiate between two and what are the management of both. Does it make sense, doctors? Any question from this topic, or should we move to next? Doctors, please answer. Hurry up. Doctor, how to differentiate between two? Yes, you will go with endoscopy, and then according to the history, you have to differentiate, and later on you will go with endoscopy. Firstly, you have to stabilize the patient, then go with endoscopy. And accordingly, you have to manage. Okay, move to next. Next question. Old age patient with cataract had improved vision after surgery, post-op. And day 4, he wakes at morning with painful eye blurred, single vision. What happened to this patient? What is your diagnosis? According to the diagram, these this is the picture, and according you have to diagnose. Option A, conjunctivitis. Option B, uveitis. Option C, suture infection. Option D, hypopyon. Option E, acute glaucoma. And you can see the picture, what's going on. It means majority with D and few option I can see with C as well. So the important point, the key point, post-op and patient with cataract history, improved vision after surgery. In first line, all the key point for your diagnosis. So cataract patient and after surgery, post-op and patient present with painful eye blood vision, the diagnosis hypopyon and maybe hyphema. Hypopyon, if the abscess, you can see there is abscess formation. But if in case, if the blood in eye, there is that's we called as hyphema. Hyphema. If accumulation of pus in the anterior chamber, we called as hypopyon. If bleed in the eye, what we called as hyphema. And in history, you will find out the patient have history of cataract and got surgery, and later on, because this is the most common complication after surgery with cataract patient, hypopyon or uveitis. So these are the complication of the cataract patient after phacoemulsification surgery. So answer is simple, hypobarion, and you will see this picture as well in real exam. Okay, move to next. Old male patient, sorry. Old male patient brought in by wife complaining that neighbor is spying on his wife. Think police is also following him. What is your diagnosis? Delusional disorder or paranoid personality? And this question from psychiatry. So what is your diagnosis, doctors? What you are thinking? November candidates with option A and rest of with B. Okay. So doctors, let me see the answer. Answer is delusional disorder. Delusions. Why? Delusion means uh, the patient have fast and firm belief. Fast and firm belief. Believe like there is no any ideas of reference, just fast and firm belief. Like the patient claimed that like American president talking to me, like fast and firm belief. And in case of paranoid personality, you will find out that these types of personalities always suspicious. Suspicious personality, distrustful personality, distrustful, always. And in our question, you will say that the patient is thinking like neighbor is spying on his wife. Think police is also following him. So police is also following him like fast and firm belief. There is no any reality, but patient thinking like the way that the patient is the police is following him. So we will go with delusions. There is any reference of paranoid personality. Paranoid personality is you can think like paranoid personality, but paranoid personality didn't think like the in our recalls the patient think police is also following him. So that will rule out that there is no any uh, not in paranoid personality. So the patient actually have fast and firm belief. Like psychotic feature. In psychotic, we have hallucination and delusions. So, and in hallucination, the patient is complaining like we have different types of hallucination. Auditory hallucination, visual hallucination, and tactile hallucination. So, visual, like patient is seeing something uh, different. For example, patient see that the snake is crawling in his wall, room wall, but actually there is nothing like that. So this is visual hallucination. And in auditory hallucination, the patient claim that angels are I can hear the voice of angels from my ear, but in reality nothing like that. And in case of delusion, there is fast and firm belief, no any linked with reality. Just they are talking and claiming that the things like that. Okay, move to next. Move to next question. 37-week pregnant lady presenting with the complaints of fluid leaking per vagina of 2 day duration of fundal height is 35 centimeter. On sterile speculum examination, fluid leaking through the cervix is visualized, but cervix is closed, asking for next most appropriate step. Option A, amniotomy. Option B, prostaglandin 2. Option C, oxytocin. Option D, balloon catheter induction. So, doctors, what do you think? So, doctor, in every question, you have to focus on the last line as well. What is the next most appropriate step? And focus on the age of the patient in every question. And then they are giving like blah 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 patient a medical history, past history, blah blah. But few things is important. You have to focus on that. And this patient's cervix is closed, fluid leaking through this cervix. You can the fluid is visualized on speculum examination as well. So next most appropriate step. Majority with B, but few of with C. Dr. MP Singh, Dr. Salim as well, Dr. Abdul Manan, Dr. Wes is with C, and no one go with D and A, right? Dr. Hassan Yusuf with A. Okay. Other doctors, please answer. Okay, move to answer. So, doctors, the next best step is oxytocin infusion. Oxytocin infusion. And we are taking reference from SAL. So I think here is difficult to read, so we will go with guidelines. Okay. So this is from SAL. For obstetric, you have to go with SAL, and SAL's flow chart is extremely, extremely, extremely important. Every flow chart is important. So pre-labor rupture of membrane, PROM. So first of all, if the patient present with pre-labor rupture of membrane, you have to take history, like just 1 minute. Okay. So you have to take history like obstetric history, medical history, surgical history, social history, gestational, current pregnancy, about history. And after that, you will go with examination, vital sign, abdominal examination, palpation, percussion, auscultation like this. And then you will go with examine the fetal presentation, urine analysis, sterile speculum examination, and you have to assess for rupture of membrane, ROM, and then presence of liquor like this. So after this examination, you will find out either membrane is intact or membrane is ruptured. If the membrane is intact, then no problem. You can go with you have to discharge the patient. Nothing to alarm here, so no problem. But if membrane is ruptured, then the chance to get the chorioamnitis. So this one is alarming situation. So you will go perform CTG, cardiotocography, and assess for risk factor. What are the risk factor you have to assess in this patient if the patient presenting with membrane rupture? So these are risk factor. Abnormal CTG is risk factor. GBS is positive. Group B streptococcus is positive. Or you will find out that there is suspicious of chorioamnitis infection. Or the presenting part is non-cephalic or mobile. Or meconium or blood sustain liquor. So if these risk factor is present, so you have to go with active management. Membrane is ruptured and the risk factor is present, you will go with active management. But if risk factor is not present, just membrane ruptured, you will discuss the benefit and risk of expectant management with active management. Okay. Yes. So you will discuss the benefit of active and expectant management with patient. Yes. Okay. Okay. So discuss and plan for active management. So we will go with active management. So active management means you have to admit the patient in labor ward, then commence oxytocin infusion once the rupture of membrane is greater than 4 hours. This is our answer. This is our recall. Like they are asking the patient with because fluid is leaking, so it means membrane is ruptured. So you will go with active management, and after admission, you will go with oxytocin infusion once the rupture of membrane is greater than 4 hours. Then commence continuous CTG with oxytocin infusion. And then you will see GBS prophylaxis to commence immediately if GBS is positive or after 18 hours if negative or unknown. You will go with active management. In another hand, no risk factor, but membrane is ruptured, you will discuss with expectant management and active management. And expectant management means woman, you will send the woman to go to the home. Woman may go to the home, or it's depend upon the patient wish, are admitted to the antenatal ward. If woman elect to go home, ensure she take 4 hourly monitoring of temperature. You have to advise that every 4 hourly monitor of temperature, any vaginal loss or fetal movement and contraction. And you will advise if you will feel something from that, you have to come back to the hospital. Contact to return to the hospital. When contraction become more intense and labor likely and labor color change and offensive to smell and temperature greater than 37.5 Celsius and reduce fetal movement, and if the lady is unwell, then immediately come back to the hospital, and she change her mind and want to commence labor earlier than planned. So these are the expectant management. So you have to go through with that. But in exam, the important one, what are the next step? So next step is always like you will go with oxytocin and later on other step. Any question, doctors? Does it make sense? Should we move to next? Okay. Okay. So many questions covered from this flowchart. So flowchart is extremely important. SAL flowchart. Okay. Move to next. No doctors, no. Prostaglandin have different indication. In this question, don't go with a prostaglandin. You see here in complete SL flowchart, uh, nothing written about prostaglandin. Okay. At 13 week, next question. A 13-week pregnant came for routine checkup, ultrasound done, cyst of 5 centimeter, increased vascularity with thickened wall, asking for management. Option A, MRI. Option B, oophorectomy. Option C, laparoscopic cystectomy. Option D, cancer tumor. Yes, yes, Dr. Abdul, you are right. So, what are the management here? Okay, so majority with C and few are with A, right? Okay, okay. So option is answer is MRI of the abdomen. So we will go with RSAGP guideline. Okay, okay. So investigation and management of ovarian masses. And these are few important things about protective factor. In only ovarian cancer, the OCP is protective. Those women who are using OCP, they have less chance to get ovarian cancer. And parity and breastfeeding, these are reduce the risk for ovarian cancer. And risk factor, family history of breast, colon cancer, uterine or ovarian cancer, and hereditary, these are the risk factors. So investigation. In our patient have already done with ultrasonography, and ultrasonography, they find out the 5 centimeter cyst. So the next step is always transvaginal or transabdominal. Transvaginal is have best accuracy as compared to transabdominal ultrasound. So we will go with that, and after you will find out either is the cyst is benign or malignant according to the ultrasound finding. If the border is irregular, so it means there is chance to get malignancy. And if there is uniocular, only one cyst over there, uniocular cyst, this one is benign. So presence of solid component where the largest solid tumor component, and if the fluid is present like ascites, so it will be malignant. These are the feature you will find out during the ultrasound. Presence of acoustic shadowing, and at least, okay, no, not important. And next we have, if the diameter less than 10 centimeter, so is benign. But if irregular multiocular solid cyst with diameter greater than 10 centimeter, you will think like it is alarming sign, so malignancy. And after you will go, ovarian masses may be seen on the CT and MRI. These are typical incidental finding, and assessment with ultrasonography is required. So firstly ultrasound, and then you will go with CT and MRI is best. Use of CT or MRI is assessment of the ovarian masses does not improve the sensitivity or specificity obtained through ultrasonography. So that's why you have to go with that. And after that, if you will you have suspicion that it is a malignancy, then you will go with serum CA-125 to assess the risk of malignancy. CA-125 should be measured only if the ultrasound appearance of the mass raise suspicion of malignancy. So you will go with that. So this one is not important. Next. Okay, this flow chart is important. So doctors, you have to classify the patient either is premenopausal or postmenopausal. Premenopausal is important one. Many questions from this. Post is not important. So premenopausal, if the cyst less than 5 centimeter, simple asymptomatic, not symptom, you will just reassure the patient. Reassure no further action is required. And if the cyst between 5 to 7 centimeters, simple asymptomatic cyst. So you will go for repeating ultrasound 3 to 4 months, every 3 to 4 months. If the size is increased and symptomatic, you will refer to gynecologist. Like if size greater than 7 and patient is symptomatic, you will refer this patient to gynecologist. So this how you manage the premenopausal. And what about the postmenopausal? Like if patient with CA-125 and calculate RMI, risk of malignancy index, and according to the score, if RMI less than 25 or less than 5 centimeter cyst, simple cyst, unilateral CA-125 less than 30, you will go with surveillance, repeating every 3 to 4 months. If the resolution of cyst just okay, so if resolution of cyst or decrease in size, no further follow-up required. And if no change or increase in size or development of suspicious feature, you will refer the patient to gynecologist for surveillance as well as laparoscopy. Another, if the RMI score between the 25 to 200, you will refer gynecologist directly. Oncology for laparoscopy. And if RMI greater than 200, you will go with refer gynecology for staging and laparotomy. So the way you have to memorize, just simple. And important part is premenopausal women. So premenopausal, if the cyst less than 5, just and asymptomatic, you have to reassure. If cyst between the 5 to 7, centimeter and asymptomatic, you will go with repeating ultrasound every 3 to 4 months. And if size is increased and patient is symptomatic, like greater than 7, you will directly refer the patient. Does it make sense, doctors? RMI, a risk of malignancy index, doctors. So hard to memorize. Okay, okay. Doctors, thing is simple. Just go through 1 to 2 times in your own time. So, like, just focus on premenopausal. If the cyst size less than 5 centimeter and asymptomatic patient, just reassure, nothing. And if the size between 5 to 7, no symptom, just repeat ultrasound 3 to 4 months. And if the size greater than 7 and patient is symptomatic, you will refer the patient to gynecologist. Simple. There is nothing too hard to memorize. And postmenopausal, not super important for exam, just a single read. If CA 125 and calculates the RMI less than 5 and 5, this is size less than 5 centimeter, simple uniocular, you will go with surveillance every 3 to 4 months. If the resolution of cyst, then no further follow-up is required. And if this sizes persist or increase size, no change, you will refer the patient to gynecologist for surveillance. And if RMI between the 25 to 200, you have to go with refer the patient to gynecology, oncology for laparoscopy. And if RMI greater than 200, directly refer the patient. It means between 25 to 200, you just directly go with refer the patient. And if between less than 25, you have to go with ultrasound for 3 to 4 months surveillance. If size is decrease or the cyst is resolution resolute, then no further follow up is required. And if no change, then directly go with gynecologist. Simple. Does it make sense, doctors? And the cyst size is important. In question, cyst size is important. According to cyst size, you have to go with the answer. Should we move to next, doctors? When you go in your own time, you will memorize. Okay. The reference link is attached over here, so you can go through it your own time. Okay. Okay, doctors. So move to next. AML patient, acute myelogenous leukemia patient on chemo, having fever, no focus found, hemodynamically stable patient, neutrophil count 500. What to do next? Option A, CSF. Option B, PET scan. Option C, whole body scan. Option D, IV Viptos. Option E, IV gentamicin and ampicillin. And doctors, everyone have to answer, please. Oh, so intelligent. All is with deed. Okay, let me see the answer. So Answer is IV piptaz, piperacillin tazobactam, complete name. So if the patient present with shock, you have to go with gentamicin plus vancomycin plus IV piptaz combination. And if patient have no shock, you will go with simple with piptaz. If shock, because our patient is hemodynamically stable, so stable, important. And so that's why we will go with IV piptaz. And if patient is having shock, hemodynamically stable, BP less than 90, we will go with gentamicin, vanco, and IV. Three drugs combination. Okay. Okay. Move to next. Next, 41-year-old gentleman with a concern of tongue appearance, brown, furry, and bad breath. Try treating with antibacterial mouthwash. No improvement. Takes lansoprazole daily. Smokes 20 cigarettes per day. First step. So option A, diagnosis can be made on clinical ground. No investigation needed. Option B, swab tongue for microscopic culture sensitivity. Option C, perform punch biopsy of the tongue. Majority with C, few are with A, and as well as with B. Okay. It means three answers are correct, right? Okay. We will go with guidelines. Move to the answer. Answer is perform punch biopsy of the tongue. We will take in help from DermNet as well. Okay. Okay, doctors. So basically, hairy tongue. So these are the risk factors. Hairy tongue most often occur in the adult over 40 years of age and rare in infant. And range of medication had linked to the hairy cell, including the patient taking penicillin, erythromycin, tetracycline, doxycycline, lansoprazole, because our patient taking PPI, right? So these are the risk factor to get hairy cell leukemia. Okay. So other factor that may causes are aggregated hairy tongue, including the poor oral hygienic, smoking, so drinking alcohol. Our patient also drinking alcohol, cocaine as well, and a mouthwash like chlorohexidine or peroxide containing mouthwash, or colored beverages including coffee, dehydration. So these are the risk factors. What are the clinical feature of hairy tongue? So this you can see the condition of the tongue as well. So basically, the tongue become discolored, usually brown or black, although are brown, yellow or green. You can see brown, black, like this you will see. So our question is on how to diagnose. This one is important. How to diagnose hairy tongue. So it is important to take a detailed history to establish the possible contributing factor, because you have to rule out according when you take history, the patient might be taking on some drug like alcohol, smoking, and other drugs. And investigation, next step is swab of bacterial culture, fungal scraping, and best is tongue biopsy. Tongue biopsy is definitive test. You have to go with that to make the confirmatory diagnosis. And what are the treatment? Treatment of hairy tongue is usually self-limited if desired treatment option including discontinued responsible drug or avoiding smoking and excessive alcohol intake, encouraging good oral hygienic condition, gentle tongue debridement with a tongue scraper or soft toothbrush and solution, antiseptic mouthwash, topical antifungal agent, and topical retinoid. These are the treatment. It means if patient taking drug, you have to first stop the drug, and if patient are smoker or drinker, so stop that, and then make sure the patient have good oral hygienic condition, not any specific medication for treatment. Does it make sense, doctors? Should we move to next? Hurry up, please, doctors. Okay. Okay. Move to next question. A 58-year-old guy with type 2 diabetes mellitus on metformin and atorvastatin, concerned about the statin myopathy. Urine normal, a normal color, symptom most concerning for myopathy. So option A, muscle soreness in both of his shoulder. Option B, pain in both of his knee and when walking. Option C, intermittent twitching of the right leg. Both knee when walking, muscle soreness in both of his shoulder. So what do you think, doctors? Okay, so majority with A. Okay, let me see the answer. Muscle soreness in both of his shoulder. So doctors, focus on you have to focus on the history as well. Your answer is corrected. So urine color is normal. These are clue point to think about. And then patient taking metformin along with statin. So concerning symptom for myopathy. So okay. So if patient on atorvastatin and taking metformin, this will lead to the myopathy as well, and few other drugs. So the patient categorized into the mild, moderate, and severe. Severe, if patient has severe myopathy, the patient presenting with rhabdomyolysis, and mild to moderate, the patient complaining like uh, fatigue, myalgia, like this, mild to moderate. But if patient has severe myopathy, the patient presenting with rhabdomyolysis. So here in our question, the urine color is normal, so it means there is mild to moderate, something like that. So we will go with guideline. Let me see what's the things on guideline. Okay. So doctor, this topic is also important for exam. So in mild, Mild symptom myalgia is usually associated with minimal elevation of CK concentration. So CK concentration mean if the CK concentration between 3 to 10 times upper limit of normal, you will classify it as mild uh, myopathy. Myalgias occur 2 to 7% of the patient treated with statin in randomized clinical trial. So not. Move to next. In myopathy, CK concentration are more than 10, the upper limit of normal, with or without symptom. You will classify it as moderate. Myopathy occurring in the 0.1 to 0.2% of the clinical trials, greater rate than placebo. So mild, if patient have mild symptomatic, it means the CK concentration is 3 to 10 times upper than normal. And if moderate, the CK concentration more than 10. And if the CK level is greater than 40 times above the normal baseline, you will consider it severe. And these types of more serious types of muscle damage, rhabdomyolysis, occur only rarely, but is important to recognize it is fatal and rhabdomyolysis is associated. So basically, the patient presenting with rhabdomyolysis and CK concentration is greater than 40. And in management, first of all, you have to stop the culprit drug. Stopping the drugs is only specific treatment for muscle damage. And these symptoms usually resolve rapidly within the few days to week after withdrawal of the statin therapy. So in management, next step is you have to stop the culprit drug. And the combination of the gemfibrozil and cirvastatin was largely responsible for 100 deaths from the complication of rhabdomyolysis. So this drug combination is devastating for patient, lead to the rhabdomyolysis. Okay. And muscle symptoms should be assessed after 6 to 12 weeks at each follow-up visit. So these are the important things we have discussed. So nothing important. Doctor, does it make sense? Should we move to next? Any question, please let me know. Okay. The things we discuss is important for exam, nothing else. Okay. Okay. Next question. 6-year-old boy with hyperactivity, poor concentration at school, and snoring, mouth breathing during sleep. Wake up a few minutes at night. What are the cause? Option A, adenotonsillar hypertrophy. Option B, overweight, obesity. Option C, allergic rhinitis. Everyone answer, please. So doctors, okay, before going to answer, firstly you have to make the diagnosis. For example, 6-year-old with hyperactive, poor concentration at school. So these line have another diagnosis. This is psychiatric condition. Please tell me what is your diagnosis according to these 3 point. Hyperactive, poor concentration at school, 6-year-old. Yes, doctors, this is ADHD. Yes. Attention deficit hyperactive disorder. Okay, good. Okay. So doctor's answer is you are right. So adenotonsillar hyperactive is the answer. So let me see from the guideline treatment is important and okay. So this is RSAGP guideline management of the obstructive sleep apnea. So doctors, if asked about the next step, you have to go with uh, weight reduction management and best management is CPAP. So treatment option. The major treatment option available for symptomatic sleep apnea is positive airway pressure therapy. These are for symptomatic moderate to severe sleep apnea required CPAP. Okay. And these are the symptom and study mild, moderate, and severe. You can go through it your own time. So if asked about the next step is the weight reduction. Weight reduction is significantly and independently reduce the both and excessive daytime sleep, 10% weight reduction. So weight reduction is important, 10% cases. So you have to go with lifestyle modification first. If lifestyle modification is ineffective, you have to go with CPAP. These are overall conclusion. So then CPAP therapy is bedside. So these are about the CPAP. Indication CPAP is first line treatment for most adults with symptomatic, moderate to severe obstructive sleep apnea or mild OSA with symptom significant hypoxemia. So these are the things which I tell you. Obstructive treatment benefits are dose depend upon the 4 hours per night. So doctors and the things which you need to know about the first of all, if asked about the next step, uh, you will go with weight reduction. If asked about the best step and patient is symptomatic, severe symptomatic, you have to go with uh, CPAP. Next step, OSA management. Next step is weight reduction. And best management is CPAP. Okay. Okay, move to next. So these are the overall conclusion from the guideline. Okay. Doctor's next question. The 47-year-old man with multiple drug resistance referred for psychotherapy, starting antidepressant. True statement regarding the side effect. Option A, SSRI with diclofenac may increase the risk of bleeding from peptic ulcer. Option B, hypernatremia is induced by the tricyclic, antidepressant, and SSRI. So, what do you think, doctors, about this side effect? Majority with B, only Dr. Jessica with A. Okay. Anyone else? Okay, move toward answer. So doctor, answer is A. Dr. Jessica is right. SSRI with diclofenac may increase the risk of bleeding from peptic ulcer. So these are SSRI reuptake inhibitor side effects in adolescent. A headache, nausea, vomiting, abdominal pain like this. And the most important side effect is sexual dysfunction. Extremely important SSRI side effect. And later on, the GIT related side effect is important. Weight gain, flushing, sweating, itches, and then psychiatric side effect like insomnia, sedation, suicidal ideation, hypomania, akathisia, agitation, hypersensitive. So these are psychiatric side effect. So SSRI, never give the SSRI with diclofenac because this will increase the chance of bleeding if patient have already history of peptic ulcer. So conclusion, this is increase the risk of hyponatremia for all, including antidepressant. So it will lead to the hyponatremia as well. This strong association between the hyponatremia and antidepressants found in the SSRI. So never go with this combination. So these are the references as well. Okay, doctors move to next. A lady comes to clinic with mentally retarded and girl complaining of menorrhagia. She says she has been suffering from menorrhagia ever since menarche and non-compliance with the oral drug. What are the best management? Option A, Implanon. Option B, Marina. Option C, IUCD. Option D, OCBs. So doctors focus on the patient is mentally retarded, complaining of menorrhagia. Extremely important word to make your diagnosis. And non-compliance with OCPs, oral drugs. What is the best management? These are our clue points. All with B, right? Majority with B option. Okay. Okay. Should we move to answer? I think Dr. Salim and Dr. Jessica is also with B. Okay. Move toward answer. Answer is Marina. Why? Let's see from the question as well. So, for example, if patient presenting with menorrhagia, heavy menstrual bleed, if asked about the next step, this is management. If asked about the next step, next best step, initial step, these are all same. So next step is always OCPs. But if asked about the best step, best management, like in this question, they are asking about the best management. So best management is always marine, long-term management. Years of management, like 3 to 5 year management, we will go with that. So these types of questions you will face during exam, and exactly this question in my exam as well. So if asked about the next step, you will go with OCP. If asked about the best, you will go with Marina. And the patient They are also mentioning about the patient is non-compliant with oral drug. So don't think about OCP. This is gone. And best management, and patient is on have menorrhagia, so best management is Marina. Okay, doctors, good. So Marina is designed to last for 2 years longer than Implanon with the 5-year lifespan. So Marina is best offered as treatment for heavy menstrual bleed, menorrhagia, whereas Implanon is purely a contraceptive device. Okay, okay, doctors, move to next. So female patient with long-term treatment with risperidone who notice that milk come out from her nipple. What is the best management? So sees risperidone, increase the dose of risperidone, switch to quetiapine, add to bromocriptine. Doctor's answer, please. Okay, it means most majority with C and few with D as well. Okay. Okay, let me see the answer. Switch to quetiapine. Switch to quetiapine is next step. Next best step. So, doctors, as we know that we have two types of antipsychotic. Two types of antipsychotic medication. Psychotic. One is a typical antipsychotic, and second one is atypical. Atypical antipsychotic. Typical antipsychotic nowadays less used because they have a adverse effect like extrapyramidal effect. So that's why less used nowadays. And typical antipsychotic, also known as first generation antipsychotic, first generation. So in typical antipsychotic, we have medication like haloperidol, haloperidol as well. We have fluphenazine. These are typical antipsychotic, and many other drugs like pimazide. These are typical. So what about the atypical? Our question from atypical antipsychotic. Atypical antipsychotic, as you see here, a lot of atypical antipsychotics. We have aripiprazole, clozapine, olanzapine, quetiapine, diprasidone, amisulpride, risperidone, and zutipine. So these are atypical antipsychotic, and nowadays most commonly used atypical antipsychotic because atypical antipsychotic have less adverse effect and typical is a very harmful adverse effect like uh, the side effect is extremely important. Doctors, these drugs are extremely important, so that's why I am explaining that. So typical antipsychotic, we have haloperidol and many other drugs, and the side effect is important like side effect, the patient have acute dystonia as well as the patient have akathisia. and patient have Parkinsonism like symptoms, Parkinson like symptoms, and patient have tardive dyskinesia, dyskinesia, and every symptom have different type of management. So for acute dystonia, we have to go with benztropine, RX benztropine. In case of acute dystonia. And in akathisia, we have to go with beta blocker like propranolol. And in Parkinson like symptom, we will go with benztropine or amantadine. Benztropine or amantadine. And for tardive dyskinesia, we have to go with some atypical antipsychotic medication. Like we will go with clozapine or aripiprazole or something like that. And in tardive dyskinesia means the patient is moving their tongue in their lips like that. So these are about the typical antipsychotic medication side effect and their treatment. Now we are discussing our question about the typical, atypical medication side effect. And our patient is on risperidone and no complaining the galactoria. So what are the next best step? So next step is always you have to taper off the drugs and then change the drug to another class. So that's why we have to shift the patient to quetiapine as well. So quetiapine have prolactin sparing, have less adverse effect of prolactin. Prolactin, these drugs are prolactin producing. So the important one and favorite for exam is risperidone. You will see articles on risperidone and no patient complaining the milk is coming from her breast. So what is the next step? Next step, taper off. Along with taper off, you have to change the drug. Like you can shift the quetiapine, you can go with aripiprazole or other drugs. Other clozapine also have very severe side effects like cardio toxicity, cardiomyopathy, and as well have some uh, adverse effect on blood, agranulocytosis. So that's why we will choose less. And clozapine, we have to go choose for resistant schizophrenia. These are recalls. Clozapine is treatment of choice for resistance schizophrenia. Clozapine and olanzapine have some metabolic side effect like the patient taking olanzapine and know the patient weight is increased. So obesity, uh, the patient complaining of obesity after taking the olanzapine as well. So let me show you some important, more side effect from atypical antipsychotic from my notes. Okay, doctors. So doctors, see here, this is important chart how you can memorize the side effect of typical atypical antipsychotic. So doctor, these are all drug classification, all these drug classification, and Risperidone. Firstly, we will talk about the risperidone. So see here, risperidone have +3 for hyperprolactinemia. So memorize here. So these are have side effect like patient complaining of hyperprolactinemia as well. Another you will see here, the patient are complaining as well weight gain. But the important side effect is risperidone. You have to memorize just hyperprolactinemia. Second, okay. Second, you have to memorize the clozapine as well. Clozapine side effect like anticholinergic side effect +3, and patient complaining of dyslipidemia as well as hypotension and weight gain, sedation as well. So these are the side effect of clozapine as well. Olanzapine, okay. So doctor, about olanzapine is important. Olanzapine have side effect like you can see here, weight gain is very important for adverse effect of olanzapine, and as well as hyperglycemia. Olanzapine is metabolic, have side effect on metabolism, so that's why, and dyslipidemia. All these two leading cause of weight gain, dyslipidemia as well. And you can see here from all atypical antipsychotic, only amisulpride drug have very, very less adverse effect. Only just hyperprolactinemia, other is less adverse effect as compared to the other antipsychotic medication. Quetiapine and other drugs have also less, but one of the most amisulpride have less adverse effect. Doctor, does it make sense? I know it is hard to memorize all these drugs at this spot, but one by one you can go through it your own time. Does it make sense, doctors? Are you guys with me or sleeping? Okay, so doctors, this table is extremely important. So all medication side effect written here. Okay, okay, okay. Just go through it your own time as well. In your own time, you will memorize, inshallah. Aripiprazole. So doctor, mostly favorite drugs is aripiprazole as well. You can choose aripiprazole as well if patient complaining, because amisulpride have galacturia. So if patient already complaining of galacturia, so you can go aripiprazole or any other drugs. So aripiprazole, see here, this drug is also have less adverse effect as compared to other, and one of the safest antipsychotic medication. So see here, only anticholinergic 1 plus, other is negative, extrapyramidal only one, another one. So this is safest drugs in all antipsychotic medication. Okay. So important ones. So just for your understanding, important one side effect you have. Okay, doctor. So clozapine important, olanzapine important from exam point of view, risperidone is important, aripiprazole. You will at least four drugs side effect you must know. Must know. Risperidone side effect is galactorrhea, hyperprolactinemia. Olanzapine side effect, olanzapine, O mean obesity. The patient, if patient taking the olanzapine, the patient have get chance to get weight. Olanzapine, O obesity. So it is pneumonia. So clozapine lead to the cardiotoxicity. C clozapine and clozapine lead to the cardiotoxicity and as well as agranulocytosis. Aripiprazole is a safer drug, less adverse effect have. And quetiapine have some like dyslipidemic adverse effect. Quetiapine is also important as well. So, and hyperglycemic effect. Quetiapine have hyperglycemic and other like metabolic effect. So these drugs at least you must know. So the way you have to memorize one by one, 4 to 5 drugs which I mentioned must know doctors. And you will see a lot of questions from only these drugs as well. Okay. Okay, doctors, move to next. Okay, doctors, next, a 14-year-old child was brought in by mother, is non-symptomatic with normal everything. Friend is meningo positive, played scorer together a week. Know what to do. Option A, asked to come if symptom develop. Option B, give meningio vaccine. Option C, check for throat swab for meningococcemia. Option D, reassure. Doctor Hassan, why you go with why you give vaccine? And see here, the patient is non-symptomatic with normal everything. Just friend is positive. Okay, so doctors move to answer. I can see here due to ADHD. Every person have their different concept. Okay. So doctor answer is asked to come if symptom develop because no patient is asymptomatic, normal everything, just friend positive. So you have to counsel the patient and say if the symptom develop, then patient then come back to hospital. So these are the reference you can go through. Okay. Move to next. Next question. Scenario of 12-month-old boy with single partner, a single palmar crease and low set ear, asking what important investigation to request. Thyroid function, MRI brain, CT abdomen, chest X-ray, urine analysis. What is the answer of last? Last is ask the patient to come if symptom develop. Option A. So, doctor, what do you think about this? Okay, yeah, we will go with guideline doctors. So, doctor, let me see the answer as well before going to guideline. So, thyroid function test is our next step, and we will go with guideline, RACGP guideline. Just 1 minute. Okay. So this is RCH guideline. Sorry, RCH guideline. So screening for children with Down syndrome. So these are about the Down syndrome written. So this table, this table is important. A lot of question from this. So from birth to 1 month, you have to go with a chromosome analysis to confirm the diagnosis as well. So the important thing, like birth to 5 year to onward, the one things you have to go through, like ECG reported by pediatric cardiologist. You see here, birth to 1 month, birth to 1 month, and then 1 month to 1 year, and 1 year to one till 5 year, and 5 year to onward. In every visit, you have to do echo, echocardiogram. You have to do every visit, and ECG. You have to do ECG in just birth to 1 month. And about thyroid function test, you have to go with 6th and 12 month. TSH, TSH in first visit, you have to go with that birth to 1 month, but later on you will go at 6th and 12 month. TSH level. TSH level is important. So memorize this, and then later on annually from 2 year. So TSH level at birth, you have to go with TSH, and then later on at 6 month and 12 month, and after that annually from 2 year. TSH, then echocardiography, you have to go echo every visit, every single visit you have to go with echocardiogram. And about ECG, just go with ECG in first visit, one birth to 1 month. And other one, a lot of another things, so you have to go through, it's your own time, because we have less time and covered another record. Does it make sense, doctors? TSH annual from 2 year to onward, and in first visit birth to month, you will go TSH, and later on 6 month and 12 month, and after 1 year you will go annually from 2 year. So these Down syndrome screening is important. So just give a superficial read. ECG first visit, echo every visit, TSH level first visit, and then later on 6 to 12 month, and later on you will go annually from 2 year. So these three at this part, just you need to know. Okay. Okay, doctors, move to next. Antepartum hemorrhage like picture. PP 130 by 95. CTG normal. 33 week. And UTI. Previously lower cesarean section. C-section 2. Preeclampsia. Tocolysis preclusion. So option A, APH, option B, severe preeclampsia, option C, gestational hypertension, option D, UTI, option E, previous C-section. Answer about A. Thyroid function test, doctors. Last question. Yes, option A. So, doctor, basically asking about the tocolysis contraindication. Antepartum hemorrhage picture, BP is almost in normal ranges. CTG is normal, 33 week, UTI positive, and patient have history of C-section. So tocolysis for contraindication to tocolysis. Any other doctors? Dr. Jessica changed her answer. Okay. E to A. Okay. Yes, your thought process is good, Dr. Jessica, because you are near to exam. Okay, doctors, move toward answer. Okay. So, severe preeclampsia. These are contraindication to tocolysis. So, see here. So, all these contraindication like intrauterine fetal demise, lethal fetal anomalies, non-reassurance fetal status, severe preeclampsia. So, see here. Severe preeclampsia and maternal bleeding with hemodynamic instability, chorioamnitis. So chorioamnitis is one of the most important contraindication to tocolysis. And then preterm premature rupture of membrane. Preterm premature rupture of membrane. And then maternal contraindication to tocolysis. These are important contraindication to tocolysis. And for tocolysis, we have to use the drugs like calcium channel blocker, nifedipine, and and we can go with some beta agonist as well. Does it make sense, doctors? So these are the contraindications. So you must know about this. Chorioamnitis, severe preeclampsia. These two are extremely important, so must know about this. And then premature preterm rupture of membrane and maternal contraindication to tocolysis. Should we move to next, doctors? Okay. Okay. A 15-year-old is tattered soiled cloth is brought to emergency by police from park. He says that he escaped his parents because they had barricade shut the house, cutting off the internet, not allowing him to leave the house because of the COVID. What condition do the parents have? So option A, shared delusion. Option B, conspiracy thinking. Option C, schizophrenia. Option D, overvalued idea. Dr. Jessica tried to think again. Other doctors, please. So brought to the emergency by police from far, and escape his parents because they had barricades shut the house, cutting off the internet, not allowing him to leave the house because of COVID. So, what condition to do the parents have? It means give extreme importance to one thing, which reality doesn't deserve, like that. Extreme importance to one thing. Okay, let me see the answer. So, doctor's answer is overvalued idea. Dr. Jessica, I have my reasons, sir. I think inclusion because they actually do both. So, think it is fluent and is shared by both parents. So, doctors, you see here, what condition do the parents have? They are asking about the parent, not about the patient. If yes, you are right. If they are asking about the both condition, then you can share it is shared delusion. But they are asking about the what condition to the parents have, because due to the COVID, they are doing everything wrong, cutting internet, not allowing him to leave the house, barricade, and these conditions. So give extreme importance to one thing, overvalue idea. So in delusions, need not be associated with affect. Firm sustained belief, person with delusion is absolutely convinced that delusion is real, recognized as abuse. So we can we already study about this. Delusion is fast and firm belief, basically. Fast and firm belief. So overvalued ideas like associated with very strong effect. In our question, very strong effect due to COVID. COVID is a strong effect, not health firmly. Person with at least some level of doubts and it due trustfulness, not recognized by as absurd, acceptable, can occur in both healthy and mentally ill people. Does it make sense, doctors? So these conditions, they are asking about the condition of the parent. So parents giving the extreme importance to COVID. So that's why overvalued ideas. If they are both asking about the both patient and parents both are doing, so it is a shared ruin. Should we move to next, doctors? Okay, okay, doctors, move to next. So 3 or 5 year old boy present with diarrhea and later he is scratching his anus. On examination there is fissure and mucosal discharge from anus. What is the cause? Option A, E. coli, B. Giardia, option C, Candida, option D, Enterobius vermicularis. So, doctor's important point from this question is scratching his anus. This is typical point. Diarrhea, and there is on examination there is fissure. This is another distractor. You can say this is distractor. So, what is your diagnosis? Okay, majority with D. So, answer is enterobius vermicularis. So doctor, see here, for example, in case of giardiasis, the patient usually present with bloating. You will find out in history bloating, flatulence, foul smelling stool, and fatty stool, fatty diarrhea. You will find out fatty diarrhea, fatty stool you will find. In case of giardiasis, E. coli, you will find out, and they have different stain. The patient are usually present with watery diarrhea. And enterobius, you will find out there is scratching in his anus as well. So you will go through this. So these are the differential point how you can make the diagnosis as well. And candidiasis have a different clinical picture. And in giardiasis, you will find out that the patient have history of camping, camper hiker. Basically, patient campers hiker. Camping history you will find out. And presidential like bloating, flatulence, and foul smelling, fatty stool. So doctors, that's for our today's class, and hope so you will learn a lot from today as well. So any question from today's topic, please let me know.